clinical nutrition protocol for the treatment of cardiovascular disease. I'm actually going to focus largely on the science behind the protocol and the kind of evolution behind the role of pure EPA in cardiovascular disease. And then I'm going to talk about the co-therapy nutrients that we also recommend, the science behind those as well. So, kind of goes without saying, this first slide, and you should all know it well, but unsurprisingly, diet and lifestyle heavily correlates with a large number of cardiovascular disease risk factors, everything from lipid profiles to high blood pressure, being overweight, metabolic syndrome factors, and of course, therefore, it makes sense to look at dietary-based approaches to prevent and also treat various different cardiovascular complications. So as I said, being Igennus, being omega-3 and specifically EPA fatty acid specialist, this is where I'm going to focus most of the talk. So without dilly-dallying, here is the research. So from the 1950s, there's been quite strong observational reports of links between low cardiovascular disease and the Greenland Inuit. This was further investigated in the 1970s, and they realized that it seemed to be the large amount of fish and marine products consumed by the Inuits, and therefore the intake of omega-3 fatty acids, specifically EPA, that contributed to low incidences of cardiovascular disease. When comparing the Greenland Inuits to European populations, specifically the Danish, they found that unsurprisingly lipid profiles were much more healthy and much lower in terms of cholesterol, triglycerides, as well as the LDL proportion of cholesterol being much lower in the Inuit versus the Danish Europeans. Of course, also alongside with that, they noticed that primarily in the Inuits, the predominant fat was the omega-3s. Converse to that, you get high levels of omega-6 or higher levels of omega-6 in the European populations. But they also noted that those Inuits who had migrated to Denmark had much higher and more comparative omega-6 levels to the Danish population. So this is where the real link between dietary intake and omega-3, omega-6 fatty acid status was linked to cardiovascular risk. So this is just a profile, the fatty acid profile that was taken. So despite the fact that the Danish population actually had higher total fat intake in terms of calories, the polyunsaturated fatty acid levels and the omega-3 to 6 ratio was much worse in terms of cardiovascular health. And also, interestingly, despite the fact that Inuits had lower cardiovascular incidence, they had higher overall cholesterol. So there's something going on here that had to be further investigated. Similarly, when you look at old and newer studies of the Japanese population, when you compare the farming population, the inland population with the fishing population, you see a similar pattern. So the fishing population were obviously eating much higher levels of fish, getting much higher levels of EPA. Their arachidonic acid to EPA ratios as a result were much more preferable, and their total red blood cell omega-3 levels were much higher as well. The farming Japanese population still on the good side of the red blood cell omega-3 percentage there, but those eating fish had a much more favourable profile. And then looking at the little table just at the bottom there, you can very clearly see that this arachidonic acid to EPA ratio heavily seems to correlate with the increasing incidence of cardiovascular disease in different populations. So the Inuits being the lowest, Japanese are associated with very low cardiovascular complications, getting worse in Europe, but still protected, possibly largely due to the Mediterranean diet effect in certain areas of Europe. And then obviously when you get to America, it's faring much worse. So as the profile of omega-3s and omega-6s within our red blood cells seems to so heavily be a factor in cardiovascular risk, more and more studies have looked at this correlation. And in a meta-analysis carried out in 2004, over 200,000 participants were looked at across an average follow-up of 12 years, and unsurprisingly, fish consumption correlated very strongly with reduced risk of fatal cardiovascular events. And even just eating one portion of fish per week was enough to significantly reduce cardiovascular related deaths, specifically coronary heart disease in this case, by as much as 15%. And by eating more fish, there was a greater protection from mortality from coronary heart disease, and as little as 20 grams per day of fish intake was enough to lower mortality rates by around 7%. So it's pretty clear that there is a very strong relationship between fish consumption and protection of cardiovascular events. And the studies included in this meta-analysis that followed populations for longer actually saw greater improvement. So it sort of goes without saying, we all know it, the longer you eat well for, the more healthy you're going to be long term. So the populations that were followed for significant amounts of times, the people who were eating fish regularly for much longer, there was a much greater impact of that in terms of their health. So this is just a graph showing the outcomes of that meta-analysis, and you can clearly see there that with every increase in portion of fish eaten per week, there is quite a major drop in terms of relative risk of cardiovascular complications. So obviously this is getting increasingly more interesting to the medical profession and research groups, so further studies have been carried out, and this time in 2002 Albert and colleagues looked specifically at fatty acid profiles and whether or not we could understand specifically which fats were important. So they took a very, very large cohort of physicians, followed them for a period of 17 years, and then within that large cohort, they actually took a number of cases who had died from sudden cardiovascular disease-related death. And this cardiovascular disease-related death was actually the very first manifestation of cardiovascular disease in those who died. So they measured the fatty acid status of the people who died from cardiovascular death and matched those physicians with a number of controls. So it was roughly 2 controls per case of cardiovascular death, and they were matched for both age and smoking status, so to eliminate any confounding factors. And after the adjustments for lifestyle, it was seen that there was a huge risk reduction, 90% in those with the highest omega-3, total omega-3s being EPA and DHA levels in their red blood cells versus those with the lowest. So that's a pretty significant change in reducing risk there, and that graph just shows the outcome. So you can see across the bottom there, most people in Western society tend to hover sort of below the 4%, if not less, of total omega-3 EPA and DHA within their red blood cells. So it's no surprise really that we're at such huge risk of cardiac complications, but even just by increasing by around 1.5% of the total EPA and DHA in our red blood cells, we can have a significant reduction on that cardiovascular death risk. Frustratingly, we do obviously realise that these are all observation studies, so we do need to be careful in how we interpret these. As you well know, with observational studies, it's almost impossible to rule out the specific thing that you're looking at being a surrogate marker for general health, healthy lifestyles. People who eat more fish tended to be more aware of health, tended to exercise more, to smoke less, and have much better body weight as a total. So despite the fact that all of the studies, including the meta-analysis, underwent stringent inclusion criteria, it's still a factor that we need to consider, that lifestyle is something that tends to correlate with itself. The healthier the specific behaviour, the healthier your other behaviours tend to be. So you can't rule out and you can't prove cause and effect. So this, of course, has led on to a number of studies that have allowed people to establish whether or not there is a causal relationship. These are the good quality randomized placebo-controlled trials, and there are now some really, really huge cohorts being studied when looking at omega-3s and cardiovascular disease. The first listed here, it's actually a pretty old one now, is the DART study. So just over 2,000 male heart attack patients were followed for 2 years, and they were randomly assigned to either be recommended that they eat 2 servings of fish a week or no intervention at all. And the group that consumed the 2 portions of fish per week for 2 years had significantly improved outcome in terms of all-cause mortality and ischemic heart events risk as well. Similar story in the GISI trial, over 11,000 patients who suffered from a myocardial infarction, randomized to receive either placebo or a 1 gram a day fish oil supplementation. And again, we see significant reduction in cardiac death as well as sudden death over the 3.5 years follow-up. Now, the Japan lipid intervention study, which I'm going to talk about again a bit later, this one actually used specifically EPA alone, but again in a huge cohort of just under 20,000 Japanese patients with high cholesterol. They were already taking statins, and they were randomized to receive statins alone or statins with EPA, and followed for just over 4.5 years. And again, the intervention resulted in significant reduction in major coronary events over the 4.5 years follow-up. So off the back of both the observational studies and to some extent the newer published RTCs, we end up with a number of recommendations from both the American Heart Association as well as the UK Food Standards Agency. And that is quite simply to increase our fish intake, but even just by a small 2 portions a week seems to be enough. And for those people with an established cardiovascular complication, 1 gram a day of EPA and DHA was the recommended amount of intake. The Food Standards Agency in the UK goes 1 step further than that to actually break it down into oily fish and white fish, making sure you get at least 1 oily fish portion a week, and the aim there is to deliver a minimum of 450 milligrams of total EPA and DHA daily. In reality, unfortunately, the average UK inhabitant eats less than their 1 portion of oily fish a day, and in fact there are lots of people, as I'm sure you've all encountered, who eat no fish and potentially no meat as well, so they've got very, very, very limited omega-3 intake in total, and this, as we know, becomes a problem. So with the understanding that omega-3 levels are impacted by fish intake and that this also therefore impacts on cardiovascular health, a number of research groups have further sought to understand the actual role of omega-3s not only in the protection of cardiovascular health but also in understanding risk. So they're starting to be used increasingly as biomarkers, whereas cholesterol and inflammatory cytokines particularly might have been relied on previously. Omega-3s are consistently becoming used for cardiovascular risk prediction. The omega-3 index is the most established currently, and this relates to the total EPA and DHA content of our red blood cell membranes, and it's expressed as a percentage of all of the fatty acids that make up our cellular membranes. And although the omega-3 index actually specifically reflects the red blood cell percentage of EPA and DHA, it does correlate very well with our tissue omega-3 index as well. So it can be used very nicely as a marker because it's much easier to take out a little bit of blood than it is to chop off a bit of muscle or a bit of the heart tissue, which I don't recommend to anybody. In addition to correlating well with tissue fatty acid levels, it also, the red blood cell content of EPA and DHA correlates well with plasma and whole blood, again making it easy to use this in analysis because it's much easier to extract EPA and DHA from plasma than from red blood cell membranes. And the lovely thing about the omega-3 index is it's a fantastic predictor of long-term fatty acid intake. So it actually becomes a very useful biomarker of nutritional status, whereas plasma EPA and DHA levels may be affected dependent on what you've eaten most in the last few days. The red blood cell levels do seem to be quite stable, and as we know, omega-3 and fatty acid profiles within our red blood cells turn over and change relatively slowly, so you do need to stick with a certain dietary change or a certain supplemental intervention in order to see that change. So it's a very nice way of understanding the benefits and the changes of any specific dietary alteration as well. As I said, the omega-3 index reflects well fatty acid composition of tissues. That also goes for cardiac muscle itself, so we can directly understand the levels of EPA and DHA in the heart muscle just by looking at what's going on in the red blood cell. And also, to further sort of establish this as a useful biomarker, the half-life and the rate at which the omega-3 index will return back to baseline after a dietary or supplemental intervention is removed takes quite a long time in comparison to that of the serum. So it does become a very useful tool in terms of predicting risk and things going on within the various different tissues. So this graph just shows what we would expect, that the more omega-3 you're giving on a daily basis, the greater the level of change in that omega-3 index. So as you can see, for every half to a gram increase, you're getting a good 2 to 3% change there in the omega-3 index. So it does work and it's worthwhile. So this is just to show that based on all of this understanding, based on the correlative data and the meta-analyses, it's been determined that cohorts with an omega-3 index in the red blood cells of greater than 4 have much greater protection against cardiovascular events. And the optimal levels, I believe, is sort of in excess of 6.5% and ideally 8% or above. So that's all well and good knowing what we should be aiming for, but if we don't know how to get there and what factors are going to impact on that, then how are we going to know whether or not we're doing the right thing and whether or not we're protecting ourselves? Obviously, an initial fatty acid profile is going to be really helpful. But then once you've got your blood profile levels, you want to know, depending on your size, your age, your baseline status, what sort of levels you want to be intaking. And thankfully, this research has actually now been done. So a group headed up by Flock was looking at this very thing and trying to understand, okay, so this is my omega-3 index. What factors are going to affect how quickly and how effectively I can raise that profile, and what doses am I going to need to take? So it was actually conducted as a randomized placebo-controlled trial. It was double-blinded, and they were given various different doses of fish oil for 5 months, which, if you look at any dose response curve and any absorption curve of fatty acid profiles, you will see that that's quite a good length of time to see really good turnover and change of the red blood cell profile. So the aim, of course, was to develop a predictive model that would allow the researchers to be able to tell people, right, this is where you are now, this is what you need to do to get to that ideal 8%. And they found that, unsurprisingly, the dose of EPA and DHA given was it correlated with the omega-3 index. So the omega-3 index was affected by the amount of EPA and DHA given. The more you were given, the greater the elevation in your omega-3 index. Omega-3 index at baseline and your DHA levels in the red blood cells were also very useful in predicting the level of change of omega-3 index. And similarly to what we see with lots of studies involving omegas, those individuals who had the lowest baseline omega-3 index experienced the greatest level of change. As I'm sure you'll all understand well, if you're very low on something, you obviously have a much greater capacity for change. So it does make sense that those who were already quite low in the omega-3s were able to incorporate an uptake because they had much more flexibility in terms of being able to turn over those fats and alter the profiles. The amount of EPA and DHA that was given, adjusted for according to body weight, was also very useful in predicting change in omega-3. And again, unsurprisingly, the more EPA and DHA given per kilogram of body weight, the greater the rise in the total omega-3 index response. So this is the graph and the table of raw data there, just showing you the change. So hopefully you can see that along the bottom there you've got the various different dosing strategies of EPA and DHA in milligrams per day. And then up the x-axis, the right-hand side, you've got the change in the omega-3 index of the red blood cells. And you can see that that's expressed as a percentage. So the higher the dose, the greater the elevation. But again, as we see commonly in scientific studies, the greater you get away from kind of baseline, the more of the spread. And that would be accounted for by the fact that different people are going to have different initial baselines and different body sizes, etc. So that would account for the larger spread in data. But you can see from the table at the bottom there, if you're familiar with the scientific representation of statistical significance, that anything above 600 milligrams per day showed significant changes in omega-3 profile versus baseline. So that's quite useful to know there. So the key things that were considered to influence the variability in the data were age, whether you were male or female, and how active you were. So those with the lowest baseline omega-3s and those who were older actually saw a greater rise in omega-3 index. Those who had high physical activity also tended to have the higher omega-3 index. And interestingly, perhaps not given what we know about the slight ineffectivity of the metabolism of various different omegas in males, females were actually able to increase their omega-3 index, as it were, slightly better than men, although this was non-significant. And as I mentioned, that does kind of support data we've seen in other areas of science, specifically neurodevelopmental disorders, where boys tend to have worse processing and metabolic mechanisms for the fatty acids. So men seem to need slightly more support when it comes to the omegas for changing profiles. Final point at the bottom there, and again, perhaps unsurprisingly, body weight was the biggest influencer on the dose. It makes sense that the bigger you are or the smaller you are, the more or less of the omega-3 you're going to need to change the fatty acid profile. So this just shows the outcome after they'd adjusted for body weight, it seemed that you needed about 0.016 milligrams per kilogram of body weight of EPA plus DHA daily to alter your omega-3 index from around 4 to 8%. So on the right hand side there you can see how that correlates to normal human beings. So a 55 kilogram person, which would be similar to me. For those of you who've met me know that I'm quite a small female. I'd need about a gram a day of total omega-3 to get my omega-3 index up to optimal if it was hovering around the 4%. Your textbook male there would need about 1.2 grams, and then your basketball and rugby athletes are starting to need closer to the 2 grams per day to really optimize that cardiovascular benefit. So the next of our biomarkers is this arachidonic to EPA ratio. And those of you that know Igennus well and have been to our previous webinars will probably be sick to the back teeth of us harping on about the AA to EPA ratio, but it is extremely useful in not just cardiovascular disease, but chronic modern health conditions in general. Historically, we've very much been driven to believe that it's all about the omega-3 to the omega-6 ratio, and that this should be around the 1 to 2 to 1 in terms of omega-3 to omega-6, sorry, to omega-3. But actually, the more we understand the role of the individual fats, the more we realize that they need to be very specifically related to one another, and that it's not total omega-3 versus total omega-6 that predicts health outcome in specific conditions. And of course, we also know that when it comes to omega-3 to omega-6 and arachidonic to EPA specifically, the more wonderful and weird and exciting foods that we're introduced to, that our human body just has absolutely no idea what to do with, and the more unnatural these become and the more the different ingredients are added in, we start to see that foods are becoming increasingly rich in omega-6 and stripped of their natural omega-3s. Even traditionally omega-3 rich foods such as fish and seafood, and even to some extent other plants and animal fats, are increasingly suffering in terms of their omega-3 content, because the production methods are stripping that from the fats within those products. So why does this matter? Why is it important? Well, the lipids have very important roles within the body, and the reason why we focus specifically on the AA to EPA ratio at Igennus is because of the very specific and niche relationship these two fats have in terms of the inflammatory response. So arachidonic acid, as I'm sure many of you are well aware, is the key driver of the inflammatory response within the body, and largely all of the other fats in the omega-3 and the omega-6 families are heavily on the anti-inflammatory side of the fence, as it were. So they're mostly good for us. So this is why this whole idea of omega-3 to 6 ratio is not really that helpful, because if we're just totally trying to eliminate our omega-6s in favor of our omega-3s, we're actually eliminating a number of the very good for us and health promoting omega-6s as well. So when it comes to inflammation, as I said, it's really arachidonic acid and EPA that are the main players, as it were. So the two together are the key drivers and resolvers of the inflammatory response through their being the main precursors to the eicosanoids involved in the production of cytokines and inflammatory markers. And as a result, the arachidonic acid to EPA ratio becomes a very potent and effective biomarker for determining inflammatory health. And this is just to further illustrate the point. So you can see at the top there you've got two key omega-6s, of which DGLA and its derivative GLA, which isn't included there, are heavily involved in anti-inflammatory mechanisms within the body. Arachidonic acid, conversely, is very, very, very pro-inflammation. So all of the prostaglandins, thromboxanes, leukotrienes, and hydroxy fatty acids generated by the arachidonic acid fats are really, really going hard at creating inflammation in the body. EPA is really, really effective in calming down and reducing and diverting the pro-inflammatory response away from causing constant stimulation and constant problems. And the reason for this, as you can see in that far right box, is that EPA actually matches arachidonic acid in terms of the eicosanoids that are produced, but the eicosanoids produced by EPA are much, 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 much less inflammatory than the arachidonic acid ones. Now this becomes important because EPA has the ability to directly displace arachidonic acid from the cell membranes, but also having good levels of EPA reduces the activity levels of the enzyme responsible for cleaving arachidonic acid from our cell membranes. By reducing the amount of free arachidonic acid in the circulation, that reduces the level of arachidonic acid freely available to convert into eicosanoids, and having more EPA increases the levels of EPA diverting and converting into eicosanoids, and therefore you get a much greater control and balance in the inflammatory process. And then you have DHA there at the bottom, which is involved in its own special little way in the anti-inflammatory process, but by quite different mechanisms, and not quite to quite such a strong extent. So with that in mind, this AA to EPA ratio is really important in determining inflammatory health. And again, for those of you who know us well and have listened to previous webinars, you'll know that inflammatory status correlates quite heavily with a number of chronic modern lifestyle conditions, cardiovascular disease being one of them. So although I sort of keep harping on about the fact that it's not the omega-3 to the omega-6 ratio that we're interested in anymore, the numbers reflect similarly in terms of the ratio. So we're looking for a similar arachidonic acid to EPA ratio that you would expect to want to achieve with your omega-3 to omega-6 ratio. So anything up to about 3 arachidonic acid molecules to every EPA in your blood cells and your cell membranes is going to be good in terms of inflammatory health. Anything much above that and you're starting to see an increased inflammatory drive and worsening health status. So this just shows what goes on within the inflammatory process. You get your inflammatory signal, be that injury, infection, stress of any kind, and arachidonic acid is there, ready, poised and ready to switch on the inflammatory process. It pumps out inflammatory cytokines, and these escalate and attract chemokines and all of the things that you need to repair the damage being done by stress or infection via the inflammatory response. You get to a certain level where the inflammatory response is escalated, and at this point the body should be able to go, right, okay, we've repaired, we've fixed, now it's time to downplay inflammation, switch everything off and start to resolve. And that's where EPA comes in. So EPA starts to then pump out anti-inflammatory signals, as does DGLA and GLA, as does DHA to some extent. And as these signals come in, they increase, they overtake the pro-inflammatory drive and reach a point where they've themselves escalated, and that signals a stop, and then inflammation switches off. So you can see that if in comparison to arachidonic acid your EPA levels are very low, then this eicosanoid switch and ultimately this stop signal is never going to be reached, and you just have inflammation going and going and going and going and going, and it all goes horribly wrong, wreaks havoc systemically. So why is this so important when it comes to cardiovascular disease? Well, we've known for quite a long time that pro-inflammatory markers are associated with cardiovascular disease. Interleukin 6, TNF alpha, but most consistently and most prominently C-reactive protein have long been used by the medical profession and research groups to understand inflammation in cardiovascular disease. And not without just cause. C-reactive protein actually has quite a lot of advantages for understanding inflammation as well as understanding risk in cardiovascular disease. It's stable, it's not affected by circadian rhythms, and it's easily measured because it's free within the blood. But we do see that C-reactive protein concentrations, when manipulated through therapies, can actually also reduce the risk of heart attacks and death from general cardiovascular. So it does correlate itself well with cardiovascular disease. So comparing the arachidonic acid to EPA ratio, knowing its importance in inflammation and knowing its importance in cardiovascular health, we can see that there is a strong correlation in various different cardiovascular manifestations here as well. So you can see 3 bullet points there. A high arachidonic acid in comparison to EPA ratio correlates with pulmonary thromboembolism as well as angina, and actually in this particular cohort here, study in 1986, the AA to EPA ratio was in excess of 30 to 1, which is just astounding. The interesting point there in the brackets was because this was due to low EPA, so it wasn't necessarily excessively high arachidonic acid, it was just ridiculously low EPA. So that sort of then leads us on to this importance of omega-3 intake and upping that omega-3 index and getting the EPA in there. Interestingly, that last point there, in a study that was published earlier this year, being only March, that's quite impressive, the imbalance in arachidonic acid to EPA, but not arachidonic acid to DHA, was a significant factor in predicting acute coronary syndrome. So it really is the EPA that seems to be the important the 2 fats in that omega-3 index. So just quickly to look at the fact that it's useful to use the omega-3s and EPA and the inflammatory profile in determining both inflammation and cardiovascular events. So there was a couple of meta-analyses carried out here in the last year or so. And omega-3 supplementation was directly found to lower inflammatory markers in various different disease-afflicted cohorts, those with or without autoimmune disease of a chronic nature, as well as healthy people. There seems also to be a significant relationship between the amount of omega-3 given and the length of that intervention in terms of inflammatory markers within the cells. And that was specifically in non-autoimmune related diseases. So again, this kind of highlights points we've made previously in a number of talks and articles, etc., that when it comes to an omega-3 intervention, the length of treatment is really quite important, and the longer you stick with something, the greater impact you're going to have in terms of seeing benefits. And then finally at the bottom there, we see that both high arachidonic acid and CRP levels will confer risk for cardiovascular disease, and that subjects who are determined to have a high systemic inflammatory status are also likely, as a result, to see greater benefits than those without high inflammatory status in terms of prevention of atherosclerosis. Come along, slides, they're getting stuck. Right. So, knowing what we know now about the importance of omega-3 and the importance of arachidonic acid, and specifically EPA in the pathogenesis of cardiovascular disease, people have then sought to understand what the optimal levels of EPA and DHA are in a supplement, and whether there's an optimal ratio of the two, and whether one or other alone or in combination is going to be better. So there have been a couple of very comprehensive reviews that have sought to understand this further. And similarly, with previous studies in other disease conditions such as depression and ADHD, they have actually found that the ratio of EPA to DHA, not EPA to arachidonic acid, is very important in determining the therapeutic impact of a subsequent intervention. So both in depression and ADHD, it's very well established now that EPA in isolation is the key for therapeutic effect. So we can kind of sort of explain this, although the science still isn't 100% with us, unfortunately. But what seems to happen is when you take fish oil as a fish oil in its natural form, or even in a concentrated form, as hopefully most of you are well aware, it's normally in a triglyceride form. So you've got glycerol backbone with 3 different fats coming off that glycerol backbone. DHA tends to be more often than not in the same position of that glycerol backbone, whereas the site of EPA on the glycerol backbone varies quite considerably. And what happens when we digest the fats, we break those fats, individual fats, from the glycerol backbone in the digestion process. All of the particles of the fat molecule are then absorbed, taken into the enterocyte, crossed over the endothelium, etc., and then put back together. And what we see happen is that for some reason, DHA is preferentially concentrated back onto that glycerol backbone in expense of EPA. So despite the fact EPA requirements are high, EPA requirements within various physiological functions are significant, DHA tends to be preferentially absorbed, so the EPA gets forgotten and gets left out. And then what happens is, if you're consistently taking high levels of DHA, we end up with this surplus of DHA, and being the longest of all of the polyunsaturated fatty acids, it's very prone to peroxidation, and thus can be quite detrimental, increasing oxidative stress and causing damage to cellular membranes. So that's not good. We know through lots of studies that have been carried out that EPA and DHA do have quite different functions. EPA is the main physiologically active of the fats, not just in being involved heavily in controlling the inflammatory process, but also being very heavily involved in cellular communication, genetic replication, helping to regulate our stress response, cognitive function. So hugely, hugely important for the maintenance of homeostasis of all sorts of physiological functions within the body. DHA, converse to that, is a major structural fat. So the majority of DHA in our brain, in our retina, and in our central nervous system is pretty well established within the early years of life, so by about the age of 5. So we don't need huge amounts of DHA thereafter. And actually, the majority of studies, pretty much all studies, and even the EFSA claims these days, all agree that the 200 milligram per day dose of DHA is more than adequate to sustain healthy, happy DHA levels and health benefits, and that's easily obtainable by just eating a couple of portions of fish a week. So it really does seem to be important to get the EPA to DHA ratio within a therapeutic intervention correct. And as I mentioned on the previous slide, consistently we see that in inflammatory conditions and chronic modern Western lifestyle conditions, pure EPA becomes very viable as a standalone therapeutic and much more effective than EPA in combination with DHA. So here's just some of the wonderful things that the omega-3s can do and thus confer cardiovascular benefits. You've got all of the anti-arrhythmic functions, so preventing heart rate variability from reducing, so we actually need heart rate variability, and preventing related death and arterial fibrillation as a result of dysrhythmias. You've also got the reduction in atherosclerosis risk associated with good levels of omega-3, so your lipid profiles are looked after, you get plaque stabilization, and the size of the lipid particles, the cholesterol sizes actually improve with good levels of omega-3, so they're less abrasive, they're less likely to damage and lodge into the vascular wall. You also see blood thinning, which allows for improved blood flow and less likely of the blood to clot within the vessels, as well as a reduction in inflammation and adhesion of inflammatory cells and immune cells to the vascular walls, which further exacerbates atherosclerosis risk. Also, due to the impact of omega-3s allowing cells of the vessel walls to be fluid and flexible and less prone to damage, you get more relaxation of the vessel. So again, they're less likely to be damaged due to being stiff and non-flexible. So that in turn will also help to improve blood pressure. So when we look at the specific EPA and DHA ratios required to achieve optimal cardiovascular benefits, a number of studies have actually been done looking specifically at lipid profiles. So there's 3 here I just want to quickly brush over, and they all consider LDL cholesterol. And what they found, and these were mostly carried out in the last 3 years, is that EPA in combination with DHA or DHA alone will actually increase LDL cholesterol. And obviously this is not necessarily a good thing, because we're consistently told that our LDL cholesterol is our bad cholesterol. And although we know this is largely not the case, it's more about particle size and relation of LDL to HDL and total cholesterol and triglycerides and things, it's still something that seems to be causing concern within the medical profession. So studies have actually directly looked at putting cardiovascular patients with high cholesterol on an omega-3 intervention, found that their total cholesterol and their LDL cholesterol profiles actually got worse, and subsequently then switched them on to a pure EPA only intervention and seen improvements in the lipid profiles. So even something as simple as cholesterol profile seems to be positively impacted by EPA alone in comparison to a combined fish oil. So this has led on to a number of pure EPA studies, the GELIS study that I've already mentioned being one of them. So this was 20,000 patients with high cholesterol were given just under 2 grams of EPA alone, and they were randomized to receive that with statins or a placebo with statins alone, and there was around a 20% reduction in major cardiovascular disease incidence in those taking 2 grams of EPA daily. So that's quite a significant impact there. For those of you who've heard me harp on about Vascepa in the past, it's very exciting for Igennus, because Vascepa is actually a pure EPA licensed therapeutic in the US. So it's exactly the same as the formulation of our strongest EPA product, and it's being used very, very successfully in high-risk cardiovascular cohorts in the US for managing and treating cardiovascular. So thus far, it's mostly being looked at in dyslipidemia patients, triglycerides primarily, and people have been given between 4 and 2 grams of EPA daily, and 4 grams specifically seems to be very effective at reducing triglycerides as well as non-HDL cholesterol, but also in reducing other risk markers of atherosclerosis. And it does also seem to be correlating with improved cardiovascular outcomes in general. So another study here carried out last year found similar things. People with high triglyceride levels randomized to receive the 1.8 grams of EPA a day for 6 months not only found that their LDL particle size was improved, but their triglyceride levels went down and their cholesterol profile was actually improved as well. So although the LDL particle size actually went up, this didn't negatively impact on total cholesterol and total LDL levels. So very, very positive there in terms of lipid profiles. And it seemed that the EPA levels in the serum and the arachidonic acid ratio were also very useful markers of predicting risk and could independently predict risk before and after the intervention. And the great thing is, there's more to come. So from an Igennus perspective, we're very excited because they've decided that the benefits of pure EPA are so wonderful, they're going to keep studying it. So there's the Reduce It trial that's not looking just at lipid profiles and improvements in risk factor, but it's actually going to be looking at total cardiovascular events. And it's a huge trial. It's randomized, placebo-controlled. It's across 40 different sites in 11 different countries, and they're going to try and determine the effective nature and the safety of EPA in combination with statins for reducing major cardiovascular events. So that's really exciting. And it's going to take a while for those results to come out, but we'll keep you posted as to when things start to appear and we can start to understand better the role of EPA in total cardiovascular health. So we know already that EPA is a standalone and effective treatment for cardiovascular disease. It also works very, very well in combination with statins. It's now been very well accepted that the blood thinning effect of EPA is not a risk factor for people on anticoagulants. So in the last Practitioner e-news I sent out, hopefully you would have read the article by Professor Dr. William Harris, I believe, in the Journal of American Cardiology. And he was basically reviewing all of the evidence and saying we don't need to worry about fish oils, we don't need to worry about even high dose EPA, that it's very, very safe. So you don't need to be concerned about recommending EPA to your high risk cardiovascular patients, even if they are on warfarin. It is still recommended that you make sure they talk to their doctor, that their doctor's aware of what's going on so that anticoagulant dose can be reduced accordingly. But it is considered quite safe. EPA, as I mentioned, in the form of Vascepa, is a licensed therapeutic for hypertriglyceridemia, which is fantastic, and that Reduce It study is now a phase 3 placebo-controlled trial looking at EPA's benefits further. So really, really exciting things to come in the world of EPA. But of course, when it comes to cardiovascular disease, it doesn't all end there. So homocysteine is actually another area in which cardiovascular disease seems to correlate very significantly. And it's also one of the areas in which we target through our therapeutic protocols. So elevated levels of circulating homocysteine are consistently now for over 10 years a well-established risk factor for cardiovascular disease, and actually decreases in serum homocysteine levels, and increases will improve risk and worsen risk respectively. So we do want to be thinking about homocysteine levels as part of a broader cardiovascular support package. And one of the key nutritional factors in being able to regulate and protect against elevated homocysteine is in the B vitamins folate, B6 and B12, which are heavily involved in the recycling and processing and shuttling to healthy, useful products within the body of the homocysteine. So although homocysteine is sort of heavily correlated with cardiovascular disease, it's not actually yet fully understood what the mechanisms of homocysteine are in terms of increasing risk. We do, however, know that homocysteine is involved in inducing dysfunction of the vascular wall cells and also turning on programmed cell death of both the endothelial and smooth muscle cells of the blood vessel walls. It also seems that homocysteine plays a role in a number of different mechanisms that can increase the risk of atherosclerosis in the cells. And I'm going to talk about those in a little bit more depth on the next slide. The table there, if any of you want to quickly scribble anything down, these slides will be available afterwards, just shows the optimal levels for trying to achieve good homocysteine health. And obviously over the 100 micromoles per litre of blood there is starting to be quite a significant risk. So here are a number of different mechanisms by which homocysteine seems to contribute to increased atherosclerosis and that subsequent cardiovascular risk. It actually seems to be involved in reducing the availability of nitric oxide. That seems to be through oxidation of nitric oxide, and as hopefully many of you are aware, nitric oxide is a gas present within our vascular system that allows the blood vessels to relax. So having a reduced level of the nitric oxide within our blood and within our cardiovascular system is going to prevent that, and therefore blood pressure is going to increase. The vessels are going to be much stiffer and much more prone to damage. In addition, homocysteine seems to further contribute to inflammation of the vessel walls. On top of the low levels of EPA, this obviously becomes a problem. It seems to drive inflammatory cytokine production, as well as, again, that adhesion that we discussed of the immune cells to the vascular walls, which increases inflammation further. Oxidative stress is also something that goes hand in hand with elevated homocysteine, and the reason for this is that homocysteine is actually a byproduct of the process, the methylation cycle, by which glutathione is produced. So glutathione is a naturally produced, very, very potent antioxidant found throughout the body, and homocysteine, as I said, is one of the intermediary molecules in the natural biochemical process that produces glutathione. So when we have an elevated level of homocysteine in the plasma, we subsequently have a reduced level of glutathione, and because glutathione is an antioxidant, the oxidative stress occurring and damage to cells occurring can't be as efficiently combated by the antioxidant capacity of glutathione, so it further exacerbates that oxidative stress. Now, as with so many things in biology, the worse the oxidative stress gets, the more inefficient the process by which to manage the oxidative stress gets. So the less glutathione we have, the less capacity we can to prevent the cellular damage induced by the oxidative stress being caused, and the process by which glutathione is produced actually is further impacted and further reduces. So it's all just a vicious cycle in addition to the reduced levels of glutathione in circulation, the enzymes directly involved in reducing the impact of homocysteine-induced vascular wall damage that lead to the development of atherosclerosis are actually impaired. So the enzymes that actually further protect against the damage caused by homocysteine are also affected by homocysteine levels. You would have thought by this point in human evolution that we'd have come up with ways to overcome this, but I guess our weird and wonderful modern high-stress, crazy lifestyles haven't quite got there yet in terms of genes to overcome this, or otherwise we wouldn't be seeing all of these problems. But fingers crossed, genetics are capable of doing wonderful things, so hopefully some point in the future we'll get better at it and more efficient. Finally there we've got endoplasmic reticulum stress. So the endoplasmic reticulum is heavily involved in cellular communication and shuttling of various different molecules, including the lipids around the cells and to and from the cellular membranes for communication, and proteins for the ion channels, etc., pass through the endoplasmic reticulum mechanisms. And so again, by having high homocysteine levels, this is putting stress on all of those cellular and functional mechanisms, which results in a programmed cell death being switched on as a result of endoplasmic reticulum stress. This stress to the endoplasmic reticulum can be persistent, and as I mentioned, because that's involved in lipid profile, metabolism and lipid shuttling around the cells and to and from the right places within the cells, if the endoplasmic reticulum stress isn't resolved, it can actually quite significantly impact on both the synthesis and uptake of various different cardiovascular lipids, thus resulting in an increased risk of cardiovascular complications. And then finally, just there, homocysteine also, by mechanisms yet to be understood, increases the coagulation of our blood, so much more prone to thrombosis with high levels of homocysteine. My apologies for the poor quality of the image there. This diagram is actually contained in the technical flyers that hopefully many of you will have picked up either through mailings we've sent to you or at events that we've met you at, and it's also available in the cardiovascular document that will be available very shortly on our website and is going to be emailed out to you hopefully within the next couple of days in the next Practitioner e-News, but it just shows you the methylation cycle. And as you can see, homocysteine is one of the byproducts there in terms of the recycling and this process that generates all of these wonderful things that are normally so health promoting. So you've got in the, just to show you here, you've got in this part of the cycle, homocysteine converting through to glutathione there. Then you've obviously got methionine, which is a very important amino acid, but you've also got S-adenosylmethionine here, which also commonly known as SAMe, heavily involved in regulation of our mood as well. So homocysteine plays quite an important role in a number of modern diseases, of which cardiovascular is just one of them. And so going back to that earlier point on one of the first homocysteine slides, you can see here that the B vitamins are very, very important in all of these initial steps of converting homocysteine through to the next health promoting phase of the cycle, as it were. So low levels or consistently high requirements of these B vitamins, which I'm sure you're all very familiar with their role in metabolism and detox and all sorts of energy producing mechanisms in the body. When we've got this high requirement, you get this inability to process the homocysteine, and as a result it accumulates and causes problems. So meta-analysis studies are actually starting to show good results in terms of B vitamin, specifically folate, folic acid, B6 and B12 in recycling and reducing homocysteine levels and subsequently protecting against cardiovascular benefit. So that leads me on to the final nutrient in our Igennus cardiovascular process, and that's coenzyme Q10. And as far as I'm concerned, we should all be taking a little bit of coenzyme Q10 now and again because it's just wonderful and good for us. But here's why it's so important for cardiovascular health. As many of you probably know, coenzyme Q10 is very, very important for the generation of energy via production of ATP. Obviously, the cardiac muscle is one of our most energy requiring organs, and so ATP is heavily involved in cardiac function, but particularly in the contraction of the cardiac muscle, but also in the function and efficiency of the membrane channels, like the calcium sodium channel, for example, involved in muscle contraction. So it's sort of unsurprising that low levels of CoQ10 subsequently result in low levels of energy, and that has actually been considered to contribute quite heavily to cardiac failure, because the heart just doesn't have what it needs to contract and relax efficiently and be able to function, so it just gives up. So CoQ10 levels being consistently low have led to the investigation, in hand with the observation that cellular energy production requires high levels of CoQ10. This has led to the investigation of CoQ10's role within prevention and treatment of cardiovascular. And again, similarly to the homocysteine, I'm just going to review some of the mechanisms by which CoQ10 contributes to cardiovascular function. As I mentioned, ATP being the main energy currency of all cells in the body, vitally important for heart muscle contraction and relaxation via both the cross-bridging of the muscle contraction process, but also in the movement of calcium in and out of the sarcoplasmic reticulum. So low levels of ATP are going to affect both relaxation and contraction of the cardiovascular muscle. So you can see you're getting both susceptibility to heart failure as well as heart attacks when you're under constant contraction there. Similarly to homocysteine's role in the generation of glutathione, we also see a very strong antioxidative stress and antioxidant potential and role of CoQ10. So CoQ10 in its activated reduced form, ubiquinol, is itself a very potent and powerful antioxidant. So it can control oxidative stress, it can quench free radicals, which, as you're probably well aware, bounce around all over the place and cause damage to cellular membranes. They damage the mitochondria, they affect lipids in the form of peroxidation, and also damage the structure and integrity and stability of cellular membranes. But CoQ10 can also play a role in regenerating and recycling other antioxidants. So when you've got good levels of CoQ10, it will also help to donate electrons back to the likes of vitamin E, vitamin C, and lipoic acid to allow them to subsequently go on to be active antioxidants again after they've already spared their electrons for antioxidant functions. And this altogether helps to prevent cardiovascular problems and reduce atherosclerosis. CoQ10 also plays a role in helping to protect nitric oxide, so that will also then protect against negative impact of endothelium relaxation, so it prevents high blood pressure, prevents the increased likelihood of damage due to the restriction of the relaxation of the vessels. But there also seems to be a role for CoQ10 in reducing apoptosis and adhesion of, again, those inflammatory and immune cells and signals to the vessel walls in metabolic syndrome patients, so glucose seems to trigger an endothelial detrimental response, and that can induce atherosclerosis in metabolic patients. Through the nitrogen stress mechanisms of low CoQ10 levels and the impact that has, inflammatory markers are actually increased in the absence of CoQ10, so that again contributes to inflammation of the vascular walls, enhances the risk of atherosclerosis, damage, plaque formation and plaque rupture. So again, CoQ10 levels can help to prevent that. And independently, in numerous studies, because of all of these mechanisms, CoQ10 consistently correlates with a good reduced risk of mortality from various different cardiovascular complications, namely heart failure, myopathy, angina, high blood pressure, heart disease, as well as dysrhythmia. But we also see in some studies that CoQ10 levels can actually help in increasing post-cardiac surgery recovery of the heart tissue and muscle. So it's definitely something to be factoring in to treatment protocol. And then finally, perhaps something you're more aware of is statins. So the mechanism by which statins work is through knocking out this enzyme. So your HMG-CoA reductase is involved in the formation of both cholesterol and coenzyme Q10. So by getting your statins in there, knocking out the activity of that enzyme, you are going to very effectively reduce cholesterol, which in modern medicine terms is very helpful for cardiovascular and does seem to correlate quite well with reduced cardiovascular risk. But of course, once you start cutting out your ability to produce coenzyme Q10, you're going to result in all sorts of energy-related problems. Many people taking statins for longer than a year or so start to see significant reduction in energy production capacity. They get associated myopathy, so muscle pains, and it can be quite a horrible thing. So directly replacing these CoQ10 levels is going to give people on statins a much better chance of beating those statin-related complications, but also additionally, due to what we've discussed on the previous two slides, giving people all of those additional cardiovascular benefits. So that's it. That's all I want to say in terms of evidence for now. Nina has done some absolutely lovely webinars on the various different constituents of the cardiovascular nutrition protocol. So I'm just going to review those really quickly now. So this is the Igennus cardiovascular health protocol. We've got the FARMEPA, mainly step 1 that we're focusing on here, and that will restore optimum EPA levels, address your AA to EPA ratio, control inflammation, as well as improving lipid profiles. Then you've got your homocysteine control that provides you with the exact and scientifically proven B vitamin levels needed for the processing and recycling of homocysteine to prevent its accumulation and then the subsequent impact of high homocysteine. And as a result, because you've got this natural production of glutathione from the recycling of homocysteine efficiently, you've got good antioxidant support, which is going to further impact on improved cardiovascular health. Vesisorb ubiquinol, it's CoQ10 ubiquinol in the reduced active body-ready form combined with the optimized Vesisorb delivery technology. So it provides the vital energy for the optimal functioning of the heart muscle. It reduces the oxidative stress associated with low CoQ10 levels as well as systemic problems that are inducing cardiovascular problems in the first place, helps to reduce inflammation and will of course counteract any statin-induced CoQ10 deficiency. So 2 capsules of the Pharme for step 1 will deliver a gram of pure EPA a day. So for the majority of people, 1 gram of pure EPA for the first 3 to 6 months will be more than adequate as a protective restore step in a good cardiovascular health protocol. However, if you are working with clients who have an existing diagnosis of dyslipidemia, so anyone with raised triglycerides, raised cholesterol, you're looking at a minimum of 4 capsules a day in order to confer those therapeutic benefits. People with an established angina, previous myocardial infarction, you're going to need to be going more towards the 4 grams a day at least, whilst the risks reduce in order to optimize EPA levels. But as you saw from the slides we've been through, that between 2 and 4, no problem, Jessica, thanks for coming. It's all going to be available online if you need to watch the rest. Yes, so as I was saying, most of the studies do sort of currently show that the 2 to 4 grams is the optimal dosing for established cardiovascular conditions. So you unfortunately do need to be trying to get people to take those sorts of levels. But of course, some is better than none. If people can't afford it, a gram a day of EPA is still going to go a long way to conferring those benefits. And of course, looking back at those studies whereby the weight, the body mass index to omega-3 index was looked at in terms of dosing, then some people aren't going to need quite that full 4 grams a day for the benefits there. But that is our real hard-hitting omega-3 pure EPA cardiovascular support product there. We do have a vegetarian vegan alternative, the Echiomega, and the really great thing about Echiomega is completely independent and different to any other plant oil available. Echiomega, derived from Echium seed oil, is the only plant oil that's rich in stearidonic acid, which is much closer to EPA in the omega-3 family. It converts much more efficiently than ALA found in flax and linseed, and as a result you get about 25 to 30% EPA being converted to SDA versus just 5 to 8% from ALA. So for vegetarians and vegans, generally, if they have an established cardiovascular disease, there is absolutely no substitute for fish oil in the first instance. But if somebody's just high risk and very strict, then this will certainly provide them with good levels. You are looking at about 8 capsules a day as a minimum, though, for cardiovascular benefits with Echiomega, because although it is a lovely product and the only product available with rich SDA, it's still relatively low in terms of SDA levels. But just as some early proof, the benefits of Echiomega and SDA are starting to really come through in the literature. So lots of studies are being published at the moment. You can see all of those have come out in the last 2 years, showing that stearidonic acid specifically and Echium seed are really, really good for raising long-chain fat, improving human health, as well as beneficially altering cardiovascular profiles. So, Vesisorb ubiquinol, pretty self-explanatory really. It's ubiquinol, it's coenzyme Q10 in its active ready reduced form. It doesn't need to be turned into its active form in the body, unlike ubiquinone, which the majority of CoQ10s on the market are. It's 100 milligram per capsule, which is considered a therapeutically effective dose. Now, I know that lots of people do tend to recommend 200 milligrams per day for the ubiquinol use for therapeutic conditions, but for those of you not aware, Vesisorb is an amazing technology that totally overcomes bioavailability issues associated with CoQ10 and ubiquinol. Traditionally, ubiquinol is quite hard to absorb because it's very large, it's fat soluble, but the Vesisorb ubiquinol is actually an optimized technology so that when the ubiquinol hits the water content of the gut, it disperses into tiny little microparticles, much smaller than any other CoQ10 you can buy, and that then overcomes the issue of penetrating the water layer that lines the gut and preventing full absorption. So when you look at bioavailability curves, which you can see in Dr. Bailey's webinar that she did specifically about the Vesisorb ubiquinol, it gets into the blood much quicker. It peaks at more than double the CoQ10 levels of standard, even very well solubilized product, and therefore lasts at elevated levels within the body significantly longer. So it's really quite potent therapeutic and very effective CoQ10 to be using. And then finally, we've got our homocysteine control. So this delivers the exact dosing in a split dose form. So the product is actually designed to be taken in split doses. Lots of companies will focus on the benefits of a one a day for convenience, but as hopefully you know, we are, I'd say passionate, but let's say for the sake of accuracy, obsessed here at Igennus with scientific proven effect of a product. We want everything you're giving your clients to work. We want it to be scientifically tailored and 100% therapeutic. So it's designed to be spread out throughout the day. It utilizes sustained release formula, which means that the nutrients within the tablet just slowly release into the blood, which keeps plasma levels optimized throughout the day, so it can constantly just be involved in recycling that homocysteine, keeping it optimal, preventing the elevation throughout the day, rather than it just flooding the blood, the body going, I can't deal with this all right now, let's get rid of some of it. So it really is designed to be the most therapeutically effective of the homocysteine control products available. So there you have it. I'll go back to this slide very briefly. That's the cardiovascular protocol. Please keep your eye out for our practitioner e-news, which, as I said, is going out in the next few days. That's going to contain basically a Word document version of this presentation that I've given you today. So if you've missed anything, if you're confused, give that a read. And you can, of course, email me at any time if you've got any questions. There are my contact details. There are the Igennus details. Loads of really useful information on the website, as well as previous webinars. So please do go and check those out and keep an eye on your inbox for the e-news. That's the word I'm looking for. Any questions? Can I ask you to email me, because I'm aware of the time. I'm aware that I've overrun by 25 minutes or so, and I've got to race off and actually go and give a nutrition consultation now. Goodness me, I do make my life easy. So lovely to see you all. Thank you very much for coming. Please call me, email me, read more, get in touch. Kyla Williams, our London-based nutritionist, is going to be on hand all of next week in my absence because I'm going skiing. And if she can help me with anything, she will. Otherwise, I will be sneakily checking my emails now and again whilst I'm in France. So if you've got any pressing issues, get in touch and someone will be able to help. Have a lovely evening. I'll see you all soon. And don't forget to fill in the questionnaire that will pop up when you close your browser to get a free sample of Farmica. All right, take care, everyone. Bye.